Yeah, that adds your style.
You want to hand me
We're getting there. Are you guys ready? All right, Charlie, whenever you want to start, we'll get going. All right. Should I mute this? What else is coming? Charlie, there's a lot of feedback on the speaker. It's a delay. You good?
This meeting takes.
All right, there we go. Okay. Good evening, everyone, and welcome back for this year, the 2022-2023 Remac calendar, I guess. Before we get going, Marie is going to go through a roll call to assure that we are all here and accounted for.
Okay. Please respond. Robert Winchell not able to make it tonight. Joseph Schenker.
Here. Yeah, just hearing myself.
Just wait a minute.
Yeah. I'll tell you again.
Michael Batch. Robert Ackerman. Laura Ivacoli. Stuart Kessler. Matthew Fink. Wallace Carter. Eric Cohen. Kevin Mundell. Cindy Basilios. Grace Cacciola. Dario Gonzalez. Glenn Espada. Bradley Kaufman. Okay.
It's close.
Nathan Wrightson.
We have alternate.
So once Glenn announces them, they can sit as well.
Pamela Lai. Nick Alexander.
Here.
Doug Eisen.
Here. That's good.
Evan Warren. Emery Genty. Samia McKee. Allison Burr. Jeffrey Raybridge.
Sure.
Reed Caldwell. Jonathan Berkowitz. Louis Marshall. Michael Redland. Dominic Batinelli. Efren Renton. Peter Wire.
Here.
Paul Barra.
Hello.
David Pinelli.
Right. Yourself just hello, Brad.
Brad's here now. Bradley Kaufman.
Welcome, Brad.
I'll go back to that. Mary Foote. I know Dr. Foote gave me the name, but I don't have it on the list. Dr. Foote's alternate. Not here. Mark Cantor.
Here.
Sherry Skelly. Ed Jarvis. Joseph Pope. John Graves. Jessica Van Reed. Here. Benjamin Zabar. Matthew Harris. Adwa Moll Matson. Not here. Robert Krugley. Not here. Arthur Cooper. Okay, you just stepped out. Eudija Langston. Anthony Shallett. 12, 16, 17, 18, 19, 20. We have more than enough. Our quorum is 16.
Well, quorum is 16, we have 20 members, so welcome and let's begin. So first, I'd like to ask for approval of the minutes from the June 21st meeting. This was sent out via email correspondence. Anybody have any questions about those minutes? Okay, hearing none. Motion to approve. Thank you for second, Nick. Okay. Next, before we go into the correspondence report, Dr. Sayer, if you want to introduce the fellows.
Yes, thank you for the opportunity. We have our two fellows this year, get them out. And we've been moving fellow, what a relic, who are fellows, and if possible, we'd like to use them as.
Right, so the fellows can sit as alternates for if medical directors are not here. That would.
Also, the appointment, but they do have to give to by the next vote.
So at the next REMSCO meeting, that'll come up and you'll be approved to vote as alternate.
After this meeting is over, I just want to get the spelling of your name.
Okay. Next, we have the correspondence report. Marie. Yes.
Thank you, Dr. Cooper.
Thank you, Dr. Cooper.
Thank
Thank you.
But now it's official.
Emails from the following said they wouldn't be able to come to the meeting. Dr. Gonzalez, Dr. Small-Bentley, Sean Graves, Bill Langsam, Robert Ackerman, Robert Rupi, Wallace Carter, Eric Cohen, and Anthony Showers. Received emails from members alerting council and the Remac to the following shortages. I'm sure we're all familiar with the shortages: Dazolam, diazepam, dexamethasone, dextrose, thiazine, dopamine, fentanyl, Paralac, lorazepam, and lysine. All this was forwarded to protocol committee, and we're all praying that you'll be able to figure out a way to do it. QH enforcement. Joshua Feldman, Staten Island, New York, EMT 364791. Certification was suspended 1 year effective 8/9/22. Suspension is staged. Person is on probation for 3 years. Excess penalty of $500. Matthew Miller, he's from Lancaster, New York, and he had the certification surrendered. Peter Sherman, North Massapequa, VAT 335178. His certification was surrendered. And I. One second, there's one more that we just got today. No. Okay, I will pronounce the name later. There's one other person that just came in today. We also received emails from different agencies advising us about drug shortages for epi 1 in 10,000, adenosine, again dextrose, P bicarb, and liter size normal statin, and again midazolam. CME training flyer was received for vital signs registration, which is now open. And go to the website for that. Go to Ask CME. We did receive a letter from Greater New York. Actually, this is for REMSCO. They're appointing Jim Gonzalez as their primary rep of REMSCO. And we sent out agendas, minutes, and associated attachments for this meeting, the calendar for the year. And on July 7th, sent out a vote to accept proposed changes in the certification and credentialing committee administrative manual, which was approved, voted on, and being put in place. And that's pretty much it.
Do we have to, as we're all here, do we have to endorse that vote?
So the vote, because it was under the emergency rules, was okay to have it via email.
No problem.
And it could be, didn't need to be a second endorsement at this point.
Okay.
Okay, and I received from, okay, New York State Department of Health, updated stroke designation notices for the following. New York Presbyterian Will Cornell for comprehensive stroke, New York Pres Columbia, Irving Medical Center for comprehensive stroke, Mount Sinai Beth Israel is thrombectomy, Lincoln Medical Center is thrombectomy, New York City Health and Hospitals Elmhurst is thrombectomy, New York Presbyterian Brooklyn Methodist thrombectomy. The last one is St. Francis Hospital. thrombectomy. I just got this.
We get this
Notification from the
correspondence,
state is
we
new-
have to
new
read it
designations.
into our minutes.
Yeah. So these are hospitals that went through the accreditation process
Yeah.
and got approved to be.
Yes, and the state is designated.
That could be light or comprehensive.
And I
Either
can
both
forward this.
thrombectomy or comprehensive, right? There's no more
Received
like that.
that today also.
Yeah, I received the right one.
Notification.
Cool.
So
Okay.
I'll, you can have this one or I'll just email it to you.
I mean, eventually, all of the hospitals that are on our list as stroke center will have to obtain stroke, state.
Right.
Yes.
Well, once the state accreditation is complete, it won't have to be a physician directed
That's
decision. And then as a region, we'll decide if we want to, for QA purpose, have a call, but it won't have to be sent by a physician.
We probably will, but that's correct. We won't need a physician directed.
Correct.
Are any of those that are newly designated currently have designated?
There may just overlap of a lot, but I believe that they changed because of COVID. Changed
It's a change on code.
No.
I'm sure we have to change our online
Well,
listing.
Again, we'll have to compare it. I mean, we just got this, so I'm
It
sure.
literally came out like an hour ago.
Whatever update that I received so far, we already have it.
Correct, but again, we just have to make sure these are on your update. Any other questions about the correspondence so far?
I have the last notification of EMT Michael Stepcourt and from Dover, New Jersey, so I guess he works here in New York. His certification has been revoked, effective 9/22, EMT number 401626. And all of these are on the site, so if you need to see, check on your EMTs and the status is all there.
Thank you. Any questions? All right, two more pieces of correspondence. New York ASAP will be is going to be awarding a Michael Guttenberg Physician Achievement Award. They are now looking and willing to accept nominations for that award for physicians involved in EMS care. And finally, this week, Thursday and Friday, there's a Foundations of Medical Oversight course being given as a pre-conference to Vital Signs by New York NAMSP. So if anybody's interested, there's a virtual as well as an in-person version of that course. It's more geared towards paramedic and paramedic oversight QA people or physicians who are not actively involved in medical work.
I would just add that last year's recipient of the Michael Gutenberg Award was Michael Redletter. Awarded in July of days ago.
Okay, so
Gonna make any nominations now?
is there any nominations that you want Jeff to, or that this region wants to pass to ASAP?
Yep, and you can go to the New York ASAP website, newyorkasap.org, and all the nomination forms are there.
You have to be an ASAP member.
No, in fact, for this award, you don't have to be a physician. Anyone who's contributed outstanding.
Art?
Nominate. Great job.
Any other people?
Just to add to the announcement for Vital Signs, it's also a pre-conference that they for Vital Signs. in October.
That's the whole day, yeah,
Right.
EMS.
And any EMSP sponsored event. Future VMS looking at yesterday, today. The people should sign up.
Who's doing tomorrow? I'm just doing it.
Excellent. Any other questions about the correspondence so far? Okay, before we move into committee reports, I have been asked by the state over the summer to present something to you guys, which I I've always told them that I'd be transparent and do. Over the summer, like I mentioned to you last year, there was a DOJ investigation into me personally that was settled. And due to that investigation, the state has decided not to approve my vetting for CMAC. Because of that, they asked that I step down as chair of Remac. And I said to them very clearly, that is not my decision. I represent this committee and I will present it at the next in-person meeting. And if the wishes of the committee were for me to step down, I would do that. But I'm very happy and comfortable to continue to serve. I just wanted to present it here, like I said I would, so that it's officially in every record, that everybody's aware, and that I'm not, there's no hiding of anything. So that's my 2 cents. I told the state I would bring that up. If anybody has any questions, comments, or any information that they'd like to know, I am a total transparent book on this, and I'm more than happy to discuss it ad nauseum if anybody wants. I'm sure you guys want to go home instead, but I would discuss whatever you guys want to know about it. But I just wanted to do that because I was asked. So there you go. In my stead, just so you guys are aware, because I can't sit at the CMAC, Dr. Rabrich, who is the first vice chair, will be appointed or be asked to sit in the voting seat of CMAC to represent the region. Okay. That's, any questions, comments? Okay. Yes, sir.
Without making it personal, the state has made it personal. A lot of things concerned in here about precedent without necessary outcome. And whilst I think most of us who are aware of the situation find it unpalatable, to be the best way to put it, I have concerns if there's been an official outcome that's the basis of the request for removal, or it's just the allegations alone.
So the only thing, the press release from the DOJ was the reason for their decision. I was told, and again, I'm not going to divulge who told me this, I was told that it was a politically fused decision. But that's it. The allegations are the allegations. It was settled with no evidence of wrongdoing. Everything is completed. Correct.
Again, so your link not been affected,
No.
or appointment or anything else.
No.
You served this committee extremely well. Been a couple of meetings that make but you know,
Thank you.
Continue.
I'm not trying to make this, sorry.
Right. What's the process for removing?
So they cannot allow the vetting to go forward. They have to do the vetting process. If they choose not to approve the vetting, that is their choice. I don't know that there's an official process. They asked that I remove the vetting, and I capitulated because I didn't want to. Again, the goal here is not to fight with anybody. It's to try to improve EMS in our region and in the state. So I'm not looking to fight with somebody. It wasn't worth the fight. I think Jeff will represent the region very appropriately. I think Doug will be the other representative, I believe.
for next time.
So I believe that those will be the two representatives for our region. I think they'll do a great job. But again, they also asked me to resign from the committee, which I felt was not their position or their right. So that was why I presented.
And the vetting process has been ongoing for more than 2 years.
Yeah.
So they've been.
My
holding
vetting
it up,
process started 2.5 years ago.
and
So
I think.
again,
we'll be-
COVID, whatever you want to
They're
call it,
notorious
it is what it is. But that's where we're up to. So
And we could still remove you if we want.
again, there's the next vote. You can remove me anytime you want.
No, I'm trying.
If somebody, listen,
What concerns me is not the personal nature. It's the process that we end up creating for an individual anecdote. So
Sure.
should there be someone who's got a concern in the future? Should the CMAC have this kind of anecdotal or
so again, there is a process. I don't have the bylaws.
The bylaws
we didn't like that
allow,
person. There's a political thing. Get rid of them. Get us someone
There
else.
is a
There's a bylaw, you can remove the.
So there is a
chair.
there are bylaws that have instructions on how to remove
Yeah.
a sitting president. But I will tell you personally, if I was asked by anybody in this committee to step down, I would do it without hesitation because I represent you. So that is the way I look at it. And if you guys say to me, Joe, we're not comfortable, I would step down because that is how I see myself in my role.
You would have heard that already from us.
I-
This is a ask and
Again,
answer
this-
situation.
I'm just telling you that this is what they asked for. I'm presenting it. Okay. I'd like to keep moving if that's okay, unless there's any questions. All right. So hearing none, let's start with the subcommittee. The executive committee, by the way, did not meet. So I will move to subcommittee reports. We'll start with medical standards. Dr. Benelli.
Okay, thank you. So medical standards met last week, I believe, between 2 and 4 virtually. With attendance, everyone who made time during the work to attend. The only action items that are vote for forward to Remac are from the protocol committee. There's nothing further than that. CNC did not meet between last medical science meeting and the meeting beforehand. So really, I believe protocols that we're bringing forward, and I'll ask Dr. Lajas to present.
So we did have active discussion on these protocol. So I will just quickly kind of summarize discussion points as well as changes that we have.
We have to turn on the projector. That's why we have fellows. Look at that. Strong work.
I think my eyes are going.
Well, you can focus it. I still can't see it.
EFP, TOC. They're like this, or like this. Number 1, number 2.
So as everyone may recall, quite an active discussion was at our Remac meeting. We finally, I think, settled the medical standards meeting. We would like to propose narcotic. So I can read those changes. So morphine that can be in a single dose or divided doses up to 0.1 milligrams per kilogram IBIM. And that's 5 milligrams per dose, up to 0.2 milligrams per kilogram IBIM. Maximum cumulative dose of 10 milligrams for patients with a systolic blood greater than 110 millimeters of mercury. I think the sort of the change was that we wanted to be able to allow our providers to be able to have some discretion, some of their own discretion when they are dosing pain medications to patients, and that we felt that they would be able to make that decision for their patients to not necessarily give them a full dose, since we are talking about something that is for comfort measures for that patient during their transport. And there's a similar language that's also seen for the fentanyl dosing as well.
Very good.
So protocols this? Can you go down? Oh, I'm sorry, that's the general pain management, adult and pediatric protocol.
So the rationale is, I mean, this is Dr. Gutenberg's general pain management protocol. And the rationale is that so far our pain management was for specific indications for hip fractures and for burns. And now this is a general pain management protocol, which, definitely for a hip fracture, you might want to give a higher dose, but for maybe for some mild abdominal pain, you want to have the discussion to give a lower dose, at least initially. And that's the rationale for allowing, some discretion with the dosing, and the maximum doses still remain the same. So I'll open it up for discussion with them.
I have one question. How practical is to give fentanyl in that dose range? Is it for the paramedics in the room? Is it easier to give it an aliquot of 25 or 50 micrograms? Is it reasonable to pull up 90 micrograms of fentanyl, 120 micrograms of fentanyl with current?
It is a very small volume.
That's what I'm saying.
Well, there is, I think it's coming up, there is a suggested GOP change that you can go to as close.
So we feel that GOP change addresses these small, minute.
Absolutely.
Okay.
That is the rationale for that GOP.
10 microgram increments.
I rescind.
Is that GOP change like within a certain range? Is that weird?
No, we're good. we'll bring it up in a
Okay.
minute, okay? And I think that addresses, it's up to the, closest feasibly measurable,
Yes,
those that
exactly.
would reach that and not cause any, all these non-clinically significant differences that
Yeah.
make. Okay, but any discussion on this protocol, please.
I like it.
Thank you.
Yeah, so this is a forwarded motion from the protocol committee. There's no discussion.
From medical
From the medical standards committee. Medical standards. But if there's no discussion, Marie, we get to a roll call vote.
Please answer in favor, oppose, or abstain. Glenn Stada,
In favor.
Brad Kaufman. In favor. Nathan Reisman.
It's an alternate.
And I'll also
Can't see
vote.
his alternate till that after goes through. Can lie.
In favor?
Takes effect.
Nick Alexander,
In favor.
Doug I,
In favor.
Jeffrey Raybridge,
In favor.
Reed Caldwell. Michael Redlener,
Favor.
Joseph Gold,
It's okay.
always one.
Okay. Yep.
Arthur Cooper,
In favor.
Mark Cantor,
In favor.
Laura Agapoli. In favor. Kevin Munjal,
In favor.
Matthew Harris,
In favor.
Jessica Van Voorhees. In favor. Ben Zabar,
In favor.
Paul Barbara,
In favor.
David
I
Benelli,
support.
Peter Wire,
Yes.
unanimous.
Okay, thank you. Next protocol.
Next protocol.
So the next protocol is some changes, some additions to the current abdominal pain, severe nausea, vomiting, adult pediatric protocol. In addition to the modification change, I think the first one that we see here is that it's just a recommendation just to remove abdominal pain from the title. This was just thought of that just because that we do have a general pain management protocol, which abdominal pain does fall under, so that was the reason, the rationale for removing that from the title, and then just to now, so that it will now be further known as the severe nausea and vomiting protocol. The first major addition, you can see is under the EMT section, where it does state that to place an isopropyl alcohol prep pad under a patient's nose and allow the patient to inhale the vapor. There has been quite a numerous studies on this, as well as the NMSP physician statement suggesting the safe and appropriate use of this for pre-hospital providers, something that is potentially very effective, as well as something that can be also very cheap and something that can be easily be put in place by multiple agencies. The other addition is under the paramedic section, where there's an addition here that's for signs of dehydration, that crews are to administer crystalloid fluids in the 20 ml per kilogram IV bolus with a maximum of 1 liter. This is similar to some other of the protocols, it's just a hyperglycemia protocol. Just to have that crews are to administer this again, if there are signs for dehydration, to administer the crystalloid fluids.
So this is being voted as second in motion. Is there any discussion? That was not already done in medical standard.
Alright, this is thought of it, by taking out abdominal pain, we run into an issue of not having a BLS abdominal pain protocol. Pain management protocol is only for medics addressing pain management, doesn't have any of this BLS stuff that would correspond with the state BLS protocol for abdominal pain.
No, but it would still, sorry, they would still be able to treat under the BLS, other general pain management.
There is no BLS in general.
Doesn't general pain management still have a, CFR section? I don't know, because I think all our protocols.
Why don't we go down? There's not a CFR or EMT section for this.
Like the part about abdominal drink and that's that they came from the state BLS. That becomes possible.
I mean, why does pain management not have a BLS section? All of our other ones have a BLS section, don't they? We potentially an add-on to whatever else is going on.
We should put this in the pain management. Yes.
Problem solved.
So that's a very interesting question. It does also take it out of the organization that mirrors the state BLS protocols. Because the state BLS protocols have an abdominal pain protocol, we wouldn't.
But if there's nothing in the abdominal pain protocol that's relevant to us, I don't see.
This is the abdominal pain protocol. So it could
Yeah,
be-
I mean,
Maybe we
it's-
call it abdominal pain, severe nausea, severe vomiting. I don't know.
That's what.
Just to appease the state. I mean,
So they're just looking, general pain management has CFR and EMT, there's just nothing in it. So the answer is not tonight, but we need to basically copy that whole CFR section and put it into general pain management.
Okay,
I have another question about spur.
so
Just a question. The isopropyl alcohol pan and the state protocol is listed as a note, which I believe applies to all levels, including CFR. Just a question as to why we are not including this at the CFR level and only at the EMT level. It seems like such a benign thing.
I think it came out as a question because we weren't really sure that necessarily CFRs actually.
Don't have.
carry,
Okay.
alcohol from, yeah.
Good question.
Yeah.
So is there a suggestion to change anything over here or?
David?
One more question.
Yes, sir.
So does the patient have to have abdominal pain to give this medication, or can they get it for something else?
Right, that's the other
That's,
problem.
that's the reason why we crossed out the
So
abdominal.
back my
pain.
hurts, so can I have it?
You can have whatever you want.
You can still have slow.
That is why,
Yeah.
I don't know, I don't understand the rationale behind having abdominal pain up there, honestly. I don't know what purpose it serves other than making the state happy, which is important in its own right, but, I don't know that. So we have the nausea and vomiting as part of this protocol. I don't know that we have to have abdominal pain over there because I want to give it to people that don't have abdominal pain. And I think it's okay to, that's why it's the unified protocols and not the collaborative protocols and not the, you know, it's the New York State protocol, it's the New York City protocol. Yeah,
The other thing is what's there for BLS abdominal pain, for CFR and all providers is not really rocket science. Like, I'm not sure we need to cut and paste that into another protocol. We probably could live without it.
And I think the pain, like we have a chest pain protocol, because that's specific, like cardiac type chest pain, right? Like we have abdominal pain, why don't we have like pelvic pain or legs pain or, right? No, I'm just saying, like, I don't know that abdominal pain with the million different things that can cause it needs abdominal pain protocol.
so Pessa, what does the abdominal pain New York State BLS protocol have? That's such a concern.
I'm looking it up now because I don't know that there's.
Just want to make you aware that there's two protocols for the state on the website. One is the collaborative and one is the BLS protocol.
No, we're talking about the BLS protocol.
So
right now.
just-
I understand, but want to make sure we're looking at the right protocols too. Because there are two protocols on the website.
Yep.
And they have not been, this is, I think, going to need to be discussed at the next CMAC meeting as to which protocol we're following, because the state has adopted the collaborative. So if we have two sets of protocols on the website, we need to see which one we're gonna follow or which one supersedes which. That needs to be a discussion.
I think I think the one that supersedes all is the New York State BLS protocol.
Because we have not
That-
adopted.
that
has
collaborative.
not,
Not the
the
state, not
state,
taking
the
the
state is following the collaborative, along with the rest of the state. The problem is, why do we still have another set of BLS protocols up there, and that hasn't been answered, did I ask that question?
Yeah, I don't think.
It
The
hasn't been answered.
intent was that the BLS be rolled into one collaborative protocol, but you're right, it's still listed on the website.
It's still listed on the website, and it doesn't, we don't know which one to follow if you really look at it. Because the state has
so the-
unofficially adopted the
Unified
Collaborative.
protocols, New York City unified protocols have been approved by the state for us to use. We can follow those and they contain the state's BLS protocols in our unified protocols.
I'm not disagreeing with that. I'm
Right,
just
no.
saying that the two protocols, nobody even knows if they're parallel. Nobody even knows if they're saying the same thing, because nobody's compared the two.
Well, I don't. see any
So
evidence
I
of
don't
double
know
payment.
what the differences are. I'm just saying this to the first.
All right, Ben,
So just-
and then Pesach.
I agree with Aaron of dollar paying, so you know the history, the reason why it's here is because when we did the 2021 protocol, CFR had an abdominal injuries protocol. EMTs 416 had abdominal pain, and ALS had a severe nausea vomiting protocol. So to match them into the New York City unified protocol, the new protocol in 2021 was abdominal pain, severe nausea, and vomiting. So that's where it came from. But I agree with getting rid of abdominal pain here, because now it's covered under pain management. It's not in either the collaborative or the state deal. So that means we can do whatever we want.
There is there or there isn't on, in the collaborative?
It's in either.
It's in neither.
It's neither one.
We must have copied it from our old BLS.
Yeah, because the reason we came up with the unified is to
To
mimic
mimic-
collaborative. Right.
Pesach, and then let's get to the.
Just looking as well, I retract my previous question, it didn't come from the state, as Ben said, it came from our earlier protocol, there is no double.
Does not exist in the state.
So I take back what I originally asked.
All right, so either way, this is the seconded motion of change. There was no second, or there was no change suggested to this protocol that was with a motion. So this is what's on the table, and that's what we're up to. Any further discussion? If not, we'll vote. Okay, hearing none, we're gonna vote on this severe nausea and severe vomiting protocol.
Oh, severe nausea, slash vomiting. We crossed out the second severe.
Oh, right,
We
we
don't
took
need
out
the
the
severe.
second severe,
Severe.
severe nausea slash vomiting.
Please answer in favor, oppose, or abstain. Glennis Seda,
In favor.
Bradley Kaufman,
Who's on your phone?
Except that we will come back.
Pamela Lai, in favor. Nick Alexander,
Yes, in favor.
Doug Isaac,
In favor.
Jeff Braybridge,
In favor.
Jonathan Berkowitz. Michael Redlener.
Favor.
Joseph Bode. Art Cooper. Mark Cantor,
In favor.
Laura Iacocca, in favor. Kevin Monjal. Matthew Harris,
In favor.
Jessica Van Voorhees, in favor. Ben Zabar,
Favor.
Paul Barber,
In favor.
David Benelli,
Affirmative.
Peter Wire.
In favor.
Um, It's unanimous without Dr. Hopkins. voting.
So then it passes. Next.
Okay, so the next one is hopefully that will be able to address, I think, some of the current concerns that we had a little bit earlier today is going to be like in addition to the GOP section. So this kind of came about since we did change over to weight-based dosing for our protocols that at least from the 911 system standpoint, we started getting a lot of sort of like notifications that there were providers that were not giving the exact dose of the patient for the weight that was provided for the patient. So for example, a patient who was listed as weighing 78 kilograms would be given 80 micrograms of fentanyl as opposed to 78 micrograms of fentanyl, and so on and so forth. So this came about that we decided that we would like to try and make an addition to the GOP section as opposed to having this sort of like labeled individually in each protocol. So hopefully as you can read it, but I'll read it aloud, that with a few exceptions, the medications, the Remac protocols are written as weight-based dosages with maximums that refer to the maximum weight-based dose for the patient. When calculating the appropriate dose, the patient's actual body weight should be used. It is understood that weight-based dosing may lead to calculate patient doses that are difficult to accurately measure and administer. Additionally, the pre-hospital setting oftentimes necessitates the use of estimated patient weights that may also be inaccurate. Because of these issues, medication dosages may be rounded to the closest practically administered dose. It is important that the actual administered dose must be documented in the BPCR.
Any questions about this protocol or this update to the GOP?
Does that require a vote? I mean, this
So-
isn't a protocol, this is just an explanation.
So this requires a vote from the Remac to say that whether we all agree to this change. It does not, for clarification, this is not gonna go to CMAC. This will be released as an advisory if approved. And it can be released immediately. It doesn't need to wait for protocol rollout. This is just a clarification to our GOP.
And this would be an addition to B2.
This would be added as a section.
It's an additional note to add clarity.
Right, it'll
Not a
be added
protocol.
into our GOP and sent out as an advisory once approved. This does not need to go to the state for approval. Any more discussion? All right, hearing none. We don't need a roll call vote, actually, it's not a protocol, so we can actually just, take a show of hands. All in favor of this change as it reads above, please raise your hand. Anybody opposed? Any abstentions? Okay. All right, thank you, and this will go out, like I said, as an advisory. Yes.
Yes, that was my next request. If we can send this out as an advisory as soon as possible, please, and actually put it into the GOP as soon as possible.
Sounds good.
So, that would be very helpful for, our providers who could be perceived as, violating the protocols unnecessarily. And, also for our online medical control, it would be very helpful.
So Maria, I'll prepare an update for you so that you can send it out.
Okay, thank you.
You're welcome. The
Anything else?
Yes, one more.
one more item that I think that just kind of come about during our discussions, both the medical standards as well as protocol committee, was just a concern that in particular for the cyanide protocol as well as for the WMD protocol, that I think through the translation of pretty much like overhauling our protocols pretty much 2 years in a row, that there was some language that may have been omitted inadvertently during those translations, and that's the wording of the if available for both for the cyanide kits, so the hydroxycobalamin and sodium thiosulfate, as well as for basically the WMD, so the NAC, auto injectors essentially. It was never the intention, I believe, like, for these to be admitted, and it's never the intention to have everybody in the New York City system to have to carry these medications. So, I think that, it was through some discussion, I think with Joe, as well as David, that this would be the language for the if available would be added into these two protocols to make this clear, that this is just only to be as, this is not needed to have for every agency to be able to carry.
Great, Doug.
It just, what Pamela said, and again, this is different than the 911 system in terms of what we have contractual. So this is just, we brought up in a protocol by Lydia it's here, that, we left it if available in there because then it would affect the volunteers as well.
Thank you. Any other discussion on that point? So we would, again, if it was agreed upon by everybody, I think this is really just an oversight, that we will add, if available, to the WMD and the cyanogen protocol, so that it's clear that those are only needed if available. However, for people in the 911 system, that is contractual and that is appropriate.
And would we send out an advisory to that effect?
I think that's fair. It'll be in the same advisory. Put that in.
And Maria, I'll make sure that you get copies.
All
of
right.
that.
Anybody opposed to this decision? All right, hearing none, then we'll just take that as unanimous. Anything else?
The tags that report to medical standards. So John maybe will give his report here.
Yeah,
John,
sure.
because John was not there, and I can give also the ECMO tag report. But why don't we start? Sure.
So we have the inability guidelines or recognition broken up into a bunch of different sections. We have contributions on roughly 2/3 of that. Hopefully get the rest then I'll go through a review. And then bring them to this body. Again, I think that's, there's certain limitations of what the Remac can do in terms of, driving in the facility, but certainly, drawing upon the expertise in this body to provide sound guidance is something that is worthwhile endeavor. So that's kind of the next step.
Any questions for Dr. Berkeley? Hearing none. Before we leave, David, you done?
No, not yet, just,
Okay.
the ECMO tag, we had a preliminary, hospital, participating hospital meetings, where, there was actually a very good, lively discussion about the protocol, the pre-hospital portion of it. There was actually a very good discussion, and, there were some minor changes made to the suggested by the, hospital providers, to the protocol that essentially advise us to stick with the ACLS guidelines, which kind of makes sense. And I will tweak those. We put in all kinds of little comments regarding patient management that they felt was not necessarily important. So it was very good that we had that discussion. And we will present probably next meeting. We'll present the updated protocol. There's no real change in substance. It's just little things, and we'll bring this here just for approval. One more hospital has joined the group. We have already 5 participating hospitals, and that's Mount Sinai, Cornell, Columbia, NYU, Bellevue, and the next hospital that joined is Lenox Hill. Thank you, Dr. Barber. And we now have 6 hospitals participating in this pilot. The next steps are going to start to develop a regional training program. And once we're finished with that, we'll have to discuss, we'll have to train probably in person, at least partially. And Morty will have to be in touch with you as to how we implement this. And then we can hopefully launch 2023 first or second quarter. Right, that's it.
Any
I
questions?
think that, oh yes.
What were the questions? We have one more tag.
Oh, sorry. No, sorry, I apologize.
Oh, no. Sorry, there were questions for David before I just want to bring up the equipment, the technology. So we're going to finally get moving with the tag, and there's a lot of active discussion about ultrasound. Initially, I was going to schedule the first one and be on VR. I think a lot of us are looking at that for training, but I think the big interest and a lot of active discussion will do ultrasound. So, probably next week I'll start setting out some potential dates and see what the general consensus is, and also locations, so it'll be easier for people to access. We'll have companies kind of present, we'll have some closed door meetings, and more than happy to share the work that we've done at the fire department. Because we've also been looking at in the past. The one after that will be on VR, and then there's some other ones that I think we have the next couple that are planned. We'll try to do maybe every quarter if that people think that's too much, but I think there's so much out there to see. So we'll try to plan out for the next 3 quarters. Give people plenty of lead time on that.
Sounds great. Just so everybody is aware, with the governor's termination of the executive order for emergency order for COVID, statutory meetings must be in person at this point. Subcommittee meetings, tags can all be virtual. That can remain virtual, but that's part of the reason why we made this change with Remac and medical standards on different days. But now that there is no state of emergency, I guess this meeting does need to be in person at this point. Cool. Okay. Anything else from medical
That
standards?
concludes the medical center.
Okay, so before we move to QA, I just want to discuss this briefly. We had mentioned the paramedic recredentialing, that it was going to shift to a CME-based recredentialing process. There is a draft of the advisory that is coming out. One of the things that's in question, and I'm going to let Paul speak to this, is the date that this would go into effect and how it would roll out. So, Paul, do you want to speak to that?
Sure. Thank you. we had some meetings over the summer, the stakeholders, unfortunately, Mr. Ward, can't be present tonight, he has a family emergency. But we had some, offline meetings over over the summer to discuss the practical implementation of this, change. Thankfully to the input of several members of the people sitting around the table tonight, we're confident that January can be the implementation date. I think this is not going to be a situation like a protocol rollout that'll be kind of like a light switch with maybe a sunset or sunsetting of protocols. Paramedics are credentialed on a rolling basis, so we have to pull the trigger eventually. And there will be an interim phase, absolutely. And there are likely going to be candidates that require some special attention here and there. But I think it's such an important, there's multiple reasons why I want to pull this off for January. The first of which is the most humane of them all, is that the paramedics really want this. I think this is something that they really desire, and I think it's within our reach if we put our heads together and make it work. Secondly, we have increased infrastructure with the new learning management system, which there's been meetings going on about, thanks to Mr. Lax and Mr. Chang and Marie and the rest of the group. So the infrastructure is getting closer to facilitate the launch. Third, having this not on a calendar year, but on a July year, I think is a mistake, given that we don't meet a lot over the summer. And it's also in accordance with the Gregorian calendar, which we should all adhere to, obviously. And those are the reasons why I think it's important that we push for a January launch. After the meetings were, the recorded meetings were released and the vote was held, and it was one of the more interesting things I've seen in my time here at the Remac. Considering we removed backboard use and implemented new protocols, this was one that they felt very strongly about. So pushing back the date really should be done at the absolute last decision. I think in that interim phase, that January, there will be some cases that require individual scrutiny that I'm comfortable that we can, maintain our standard without having the process fully operational at that time. Operation's not the best part. At its final phase, there's going to be iterations to the process. We'll need more cowbell here and there.
Okay. Any questions for Dr. Barber?
Yeah, we appreciate the advisory potential going out because, some of our medics felt that this was a meeting. So when they were notified that, hey, you have to register for an upcoming exam, it's fine. They're like, well, no, I'm going to do the CFU research. They're like, yeah, that's not in effect yet. So we need something out there. Yeah, and the date could be something that says essentially not at this time until notified or something, because if we can't decide on a date, we don't want that to hold that back because we want to put out our own buck slip, but we want to mirror the language. So some people were shocked. They're like, what do you mean I got to take another exam?
That was the same thing. I mean, if we make it July, it's going to be.
Yeah, so whatever date.
They got to restart over the fall and the early winter. They're going to, so.
Right.
And Glenn, to your point, exactly. I forgot that. I'm sorry, but if they happen to restart in January, there's really only one regional update at that time. And we're aiming for these things in the vision to be like a quarterly thing, but the one will be the protocol updates. If you're restarting in January, you have one. So what happens if you expire before that regional update goes live? And we're going to have some executive decision making to get people through to keep them on the street. And our goal is to maintain a standard while keeping people employed, not to create hardships and obstacles for them to not be able to earn or be out there to provide care. But if you restart in June, there might be 2 regional updates or 3. And by September, it might be 5 or 6, unfortunately, but there's no equity there. The person who researched in January might have 1 to do. The person who researched in July might have 6.
Yeah, absolutely understood. Again, we just wanted something out there so our members could realize, there may not be a certain start date. It's just not in effect yet. So they're not as shocked when we tell you got to register. All right.
Morty, Scott, I mean, I don't want to I'm the tip of the spear on this, but I want you guys to be able to feedback.
Yeah, January should be doable, so we're looking at, we should have the LMS set up to be able to handle the next protocol update. We're working on, I mean, I'll just do my report now, just basically what this is about. It's gonna be set up for both the ability to present really anything that we want to present on there, including the update and any CME. So it's gonna be ready to go for whichever. In terms of how CME will work, CME will be able to flow through either by us posting it, but the ideal would be if we could have agencies all flow through the regional council's LMS. So they can run their own CMEs, they get approval, even if it's a day or two in advance, just so we could post it on the LMS. They can use their own Zoom, they could do it in person, doesn't matter. And then that way, all of the CME can actually be tracked on the LMS, and then when it comes time for approval at the very end, the button is pressed and it basically generates everybody's CME record.
Just, I've been getting questions and there's some reason, you're talking about CME, are you talking about just the regional CME or are you putting like the category B, category A?
Both.
Okay.
It's basically going to give you the ability to track your own CME online, and for the Remac liaison to do the same thing. So when it's time to now look at the total package, when everything is done and time to re-credential, it's all there.
And it may be too late for this rollout, but there's a lot of questions about some of the limits, and I understand, like, because I think the language changed from subjects for like the venues for say category B. And I sort of understand the intent is so you can't like go to a 2-day conference and get all 36 hours of your category B, but some people are wondering like, okay, if Mount Sinai is a monthly CME, I mean, to me, if they do a monthly CME every month for 3 years and you go every month, like you should be able to get your 36 hours from that, but is that one venue? So you're only limited to 12 hours, or the fire department, is that one venue?
We could provide more clarification. I mean, I think that the administrative guide, the CNC administrative guide spells it out clearly enough. We can push that out again.
It's called,
But
they term it venue. It lists a couple different categories, but then it says you're limited 12 hours per venue, not per event or per.
the idea here is going to be to break down those barriers and make it easier really to use CME. Then again, not go to a 2-day conference and just get all of your, all your entire 3 years worth of education in 2 days. The idea is to get educated throughout the 3 years. That said, the other thing that we're going to do is we're going to decentralize some of the CME approval to the individual agencies. So similar to the way that today, an agency training director, or like they do for the state, for example, or a medical director would approve your CME internally, same thing would happen here. So even on our LMS, a particular agency's training coordinator could go on there and approve particular CME or deny it to that extent. And so there would be more flexibility by agency to a certain extent to look at that. But we can clarify. I mean, that would probably be a joint thing. We can clarify those venues. So that's not
Cool. Yeah, I just want to clarify a couple of things. Like, there's a lot of moving parts to this, and the CME still underpins the medical director letter as we have it currently put. And the medical director can, for those of you who maybe in another region, they have people getting CME from multiple sides. I mean, across Community Drive, the medicine is still the same. That's what I always say, right? So if you're in Queens and you get Nassau CME, Queens, it really should have some reciprocity. And that's always been left at the discretion of the medical director, which we do not want to remove. Nor do we want to be the arbiter of 6,000 paramedics' entire CME records. That's something that's not sustainable. The real point of Morty was, with the CME, the regional updates themselves will have attached CME to them, but you still have to go out and get your CME. So, we were on the phone earlier. I think, like ASAP will track my CME, NAMSP will track, like I track my CME. Like that's what I have to do. And when the office tells me you need your CME credits, I give it in, whether it's tracked by MRAP or tracked by ASAP or tracked by whatever. But we don't expect the training and education department to be tracking the CME of every provider in the region. From my perspective, we're going to be tracking the CME attached to the regional updates, which are mandatory. The other CME they get on their own really is at the discretion, up to the provider, perhaps their agency, if they're fortunate enough to have someone who does that for them. But that CME letter comes to the medical director. If the medical director doesn't value the CME, they don't value the CME.
Any additional questions on the CME process? Sounds like this is a little bit of a work in progress, but it can start pretty quickly. And then there'll be a few bumps until we work out all the kinks, with hopefully by certain time where everybody will be on this process. Does that sound correct?
LMS is not the friendliest platform to use. Will, like the FDNY, all our members already have LMS accounts within the FDNY, will be required to be credentialed through the region, or is there a way that we could interface? So you receive it, but not everyone has to have two LMS accounts.
So I can look into interfacing, we should be having a meeting with the vendor next week. Basically, we were able to buy into the state's Vital Signs Academy. They allowed all the regions to buy into it, which was actually really good.
We thought that would be provider friendly.
It is,
The
it's
same.
most providers in the region already have it because we use it for.
Even if it's not the most provider friendly platform, it's the same one they have to use in the state.
And it's very dynamic, and it's really gonna give us the ability to do everything that we've been looking to do and then some. That is a possibility that they're gonna have to have an account there also, but I'll speak to the vendor when we can just make sure when we meet with them next week that. Let's see if there's a way to API or something.
All right, so I think that there's a few kind of hurdles we gotta go through, but it sounds like things can move along at a rapid pace. Excellent. Anything else, Morty, from training and education?
No, that was it. That was the big topic.
Okay, so then let's move on to quality assurance. Dr. Remac.
Well, we did not meet over the summer, but we have some updates related to the ongoing projects that we've got. So the primary project that we've been working on, and it's a bit laborious. That's not a word. Laborious. Yes, thank you. So it's
A lot of work.
is the a lot of work. I think it's a lot of work.
Yeah.
Very lazy.
Laborious. So is the quality dashboard related to AHA project. And it's been a long time coming. There's been ups and downs. I will say that the dashboard is almost there. The one last barrier, maybe not last, but one primary barrier right now to releasing it is that there's been a lot of discussion in the region around the quality of data, the data, how the data flows into First Watch. And we'd like to propose that we have a regional meeting, a small regional meeting of a few people who are interested in looking into the kind of how the data rolls up into the quality measures, and just give one last shot to update those so that they reflect the best quality that they can at this point. And I would propose that we do that in the next month, report back on it at this body next month, and then go forward with kind of making a recommendation to update to the First Watch group and to our regional measures around stroke and study. And then the other topics that we've been working on were because of the changes in the airway management around no need for medical for physician approval for sedation, that there was a quality assurance project that we've been working on that I hope we can also present at the next meeting related to making sure that there's not there's no problems or issues with airway management in the region because of that change.
Any
So-
questions? Dr. Remac.
No, nothing at this point. Thanks.
Great. Okay, the last subcommittee report would be RTAC. Is anybody prepared to present the RTAC information? The last meeting.
We have now, I don't think we've had our tech meeting since last year.
No, I think they're meeting second, either just before or just after STAC, which is October 12th. I want to say just before, I think Monday the 8th or whatever. I'm not.
All right, so hopefully we'll have a
October 3rd.
RTAC report at the next
Sure,
meeting.
okay.
I will say that it did come to the committee via email to discuss the recent changes to the ACS trauma criteria. I know that there's some discussion via email. This is coming here so that people who don't regularly come to the more business meetings, the protocol meetings, have an opportunity to voice their opinions, to share their input from the stakeholders, because when it goes to protocol to do the work, a lot of times it comes back here and people really don't, we kind of rehash it here again. So if there's anybody who has any input on this, please provide it now so that the protocol committee has the direction they need to help fine tune this.
Yeah, just a little background. There's been a group that's been working on this.
I'm sorry, can I just ask about the RTAC first? I think at their last meeting, there was a draft letter that went out, right, about the regional trauma system, saying that we suck, that it's terrible, there's no communication. And it was meant for comment. I'm just wondering, did you guys get any comment? Because, I mean, from our perspective, we go to the trauma center designated by the state, so.
Right.
But this was a scathing letter that essentially really said that we suck at trauma.
So the
I'm
last
just wondering what the comments were.
last art, well, it wasn't so much about the pre-hospital, but they were
Right.
saying the system as a whole was not discussed at the last RTAC meeting. The letter was not discussed.
Okay.
So,
And I'm sure you're gonna have to, because you don't want that going to City Hall or the public getting that. I don't think.
yeah, I don't think,
agree.
I don't think accurately, I'm talking reflects our system as well. I think we've made a lot of strides in our system. I think we have a fairly good system, like every other system, there needs to be improvement. So, I think the certain individuals that pushed to write that letter, it should be accepted, as, by the community as a whole. So,
But I mean, were there any
I don't-
comments?
our-
Because comments were requested. You think that somebody would say
I think
something?
it's very silent, actually. I didn't see any commentary, and or I don't know if you had any thoughts, because I know you're involved with some of the discussions about that letter.
All I will say is that right now, things are in a bit of a flux. We had an EMSC, statewide EMSC committee meeting today. DOH EMSC committee meeting, and we showed the new national protocol, you know, that's the red, yellow, as opposed to what the current model is here. There are some changes, not huge changes, but there are big changes in terms of how the protocol looks. So the plan at this point is for, at least on the pediatric level, for the pediatric subcommittee of staff to look this over at the staff meeting in Albany. Then thereafter to have a pediatric subcommittee of staff and a subgroup of EMSC meet together and, you know, see if they can come up with a proposal. I haven't talked to the leadership of the staff per se about what's going to transpire at the staff meeting, nor have I really heard anything more.
I think it was just two things. So thanks, Art, for that. And I think Ben's going over the broad changes, but it was Glenn was just talking about the letter that was initially a draft put out by certain individuals of the RTAC, basically criticizing our system, how it's a dysfunctional trauma system. And I know but that's what Glenn just asked.
That's
And
the
I said we had
letter.
discussed it at the last RTAC meeting. And, you know, I felt it was just pushed by certain individuals. I think there's a lot of positive changes. I think we have a fairly good system, like any other system needs improvement. So that's what Glenn was asking about.
Well, if you're, you know, I'm not, when was this letter sent? I'm not
It was
sure.
it was a draft and it was drafted, it was trying to be pushed to people to vote for it, RTAC, but it was put on hold for people to get a chance to give commentary, but we haven't heard
Yeah,
anything
I
about the
don't-
letter since.
Honestly, maybe I missed the meeting, but I don't remember seeing that letter. If somebody would send it to me, I'd like.
Sure,
I'd
I'm gonna
like to
send it.
see it. But there's one of the younger trauma surgeons in the system who happens to be very good, you know, but trained in a system unlike New York City, you know, where and unlike the rest of New York State, to be very honest with you. You know, this is a paper that we published back in, I guess, 2004, 2005, 6, somewhere in that range, looking at the outcome data from New York State trauma centers. And, you know, the fact of the matter is that we weren't doing any worse than anybody else nationally as a system. In fact, we were doing better. You know, but people that are schooled in the, you know, the send everything in the entire state to me, you know, kind of trauma system, think that our less, you know,
centralized trauma system, you know, is dysfunctional. That's probably the genesis of the letter. I can imagine, who probably wrote it, but, I'm not gonna name any names. And that individual, has been trying for some time to, push the notion that we have a badly dysfunctional system, because again, that individual was trained in a system where, things are different. And the problem is that the big shots in the trauma world are all, the guys and gals that make up the Committee on Trauma for the College of Surgeons, by and large are people, not exclusively, but by and large are people that are in these giant trauma centers that see 3,000 and 4,000, cases a year, that's not our system, and we don't have, and, our system grew up organically for one thing, for another, as did theirs, by the way, because there were no other major academic centers that could handle the complexity of the work. New York's different, and at least based on the data that we collected back in the day, we showed that, we were doing fine. As you say, is there always room for improvement? Absolutely. But I would like to see that letter, because I don't remember seeing it, and I think it's a vast overstatement in terms of, and when we actually look at the National Trauma Data Bank, in terms of our outcomes, really, not a lot different. Antigua, it's not a lot different.
But yeah, I definitely think, this individual threw us under the bus, during the West Side Highway Halloween, Home Depot truck incident. Talked about the trauma systems, comparing us to systems that don't even compare to ours. But it's definitely a letter you need to take a look at.
Yeah,
Because it's a scathing letter that essentially says in New York City, we're killing trauma patients with our system. That's essentially what the letter says. So you definitely want to take a look at it. I'm just shocked that those members on the RTAC committee haven't kind of pushed back a little bit. That's why I was asking if there's comments. No comments?
I haven't pushed back because I don't think I saw it.
I don't know that this committee has seen the letter. I think that
Marie did send it out. I'm sorry, I have right here.
I can write
It
a
was
letter.
sent out in April,
to
April 7th.
who?
Well, it was sent by the position that Art was alluding to, and Marie then sent it out, I think to, I forgot, I don't see who she sent to within the committee.
Was
here,
that
but
sent to the small trauma group, or was that sent to the whole Remac?
That could be possibly the case, but it came through our tech.
Okay, so let's, hold on, guys. Just so let me put things in perspective. It's now 6:30, the garage closes at 7, so I'd like to get this done in the next 20 minutes. So let's move forward, but if you could send that out to the committee, Doug,
Well,
so we could all review it.
it's still draft within RTAC, so it hasn't left RTAC, to be honest with you, so I don't think it's been.
No, then
So it
it's,
hasn't
then
been
it's not
sent to anyone
appropriate.
yet.
All right, so let's wait then
Read.
to the October meeting and see what the discussion is. Okay,
All right,
Ben.
just a quick background, I'll show what we've done so far, this is all very preliminary. So this is the old CDC guideline, and the problem with CDC is it's really written for areas that have level 1, level 2, level 3, level 4 trauma centers. And they basically said, here's, 1 and 2, those go to a level 1 or 2 trauma center, 3 should go to a trauma center, and 4 consider it. And our current guideline, which follows this pretty closely, basically combined a bunch of the 1s and 2s and said, if they have these physical findings or mechanism, you go to a trauma center, which for us is the level 1s and 2s. And then there's some of these other ones down here to say sort of consider. I'll notice that the old CDC had something like pregnancy, which we don't have. Okay. So this is the new guideline from CDC, and it's now in this red and yellow, but it's actually pretty similar, where they're basically saying these top ones should go to a level 1 or level 2 trauma center, the highest available, and then these yellow ones consider. But a lot of them really parallel what we currently have. This is the same thing, which is color coded. I was working on this with Brad and Matt Harris, and the plan was to present this to the protocol committee. Just the green are things that we basically had before, or it doesn't seem like it's a big change. The yellow are things that we added in. And I'll go over the vital signs in a second, but a lot of them don't seem like very, they're potentially should be very controversial. But they're new, they're changes, at least for our system. And then there was a couple of things in pink, which I'll zoom in, which, we felt, and people can disagree, probably wasn't appropriate for our system. One was suspicion of child abuse, does that really need to go to a trauma center? Can that be dealt with in sort of a pediatric, sort of some other protocol or advisory or something? Burns, that's probably covered under our burn criteria. And the vehicle telemetry data, I'm not sure if that's really ready or what data would that be. So at least in the draft, those were ones we didn't include. So this is the draft. This is the track changes sort of version. So changes are currently now the fire department 911 has pediatric trauma criteria, but currently the Remac does not have pediatric trauma criteria. So this is, for the idea is for adult and pediatric. Most of this is just sort of language change that hasn't changed in terms of physical finding. A big change is Glasgow Coma scale. So in the new CDC, they are saying GCS of motor less than 6. I can find where that is here at the top. All patients unable to follow commands motor 6. So that would be getting rid of the motor of 13. Cardiac arrest due to trauma. I know that there's been talk in the past of sort of termination of efforts, but in our current guidelines and the GOP say cardiac arrest and trauma still goes to a trauma center unless unmanageable airway. So to be consistent with that, that would be added here. There are the big changes, which you can see up here from CDC would be these changes to vital signs. And I think that's going to be the biggest challenge. We talked to Matt Harris, the best we could sort of come up with was just copying what they had. Though this is going to be tough for people to, to train them this whole, heart rate more than systolic blood pressure, this age cutoff of over 65, age of 10, that's different from our current, thinking about 15, but that's what CDC is recommending. And this is up for discussion. CDC says respiratory rate less than 10 or more than 29. Our thinking was, if someone has respiratory distress or ventilation, if their respiratory rate less than 10 or more than 29, for most people, they probably would fit under this. And a pediatric patient could have a normal respiratory rate of over 29. So we didn't think that was necessary, but up for discussion.
And go back up for a second.
Yeah.
I think one of the points of discussion which would have made life a lot easier, and this was feedback that was given to ACS, is the blood pressure criteria with limited groups, because we treat pediatric patients under 15 as a distinct group for the ACS. So really would have been helpful, but I don't think makes physiologic sense would be able to have a group that's sort of 0 to 15 and then 15 to whatever. The problem is that in that 10 to 15 age group is like puberty and your physiology changes dramatically. So that's why we didn't change it. So we recognize it's a flaw.
So just to be clear, the reason I wanted Ben to bring this up is because there's a lot of people who do not come to the protocol meetings. And this gives people the opportunity to weigh in. I don't want to go through the details of every protocol, of every piece of this protocol here. That is for work to be done at protocol. But if there's anybody here who has strong feelings or any thoughts on what should be or should not be included, or kind of to help give direction to the committee, is the whole point of this conversation.
Can I just give the major changes that the falls is
again, but that's something that's going to be worked on a protocol, which is again, but I don't want to have that happen here.
Okay.
Does that make sense? All right, so let's go. Mike, then Doug, then David, then Jessica.
Just one point, I think that as much as possible, one, this is right, the American College of Surgeons, it's not the CDC, this is not the CDC
That's what I was gonna
guidelines,
say.
it's just, it is,
ACS, not CDC.
it's ACS, but that's nothing. My point is that I think we should stick as close to as possible. I mean, just in principle, as much as we can stay almost, as close to that, I think that will be beneficial for us as in the long run. The second thing I want to say, just in general, is that the National EMS Quality Alliance worked with ACS to do quality measures associated with these changes in the guidelines. So I think it's worth it after we changed the protocols to think about how to do trauma quality improvement around transporting to the right place and other. Thank you.
I agree with what Michael said, and just to add on to it though. There's not a lot of change, very straightforward actually in the document, but about cardiac arrest, traumatic arrest. I think we really need to kind of address this because it puts our members at risk when, especially particular blunt trauma, especially the unwitnessed arrest. And, you know, I'd like to throw it to the protocol committee to kind of discuss looking at it, particularly blunt traumatic arrest. We know the outcome is measurable and really we're putting members at risk, you know, high risk lights and sirens, you know, going to a trauma center, bypassing other hospitals, and it's a huge risk. Thank you.
David?
Everything I want to say was already said by Michael and Doug. I just wanted to stress that this needs to go. I mean, we can go into little minute details and we'll never get the end of it.
No, that's why
That has to
I
go
don't
to
want
this-
to do
Must go
that.
to the
That's all.
protocol committee for refinement.
Yeah, Jess? Great. Matt?
I'll just quickly just add to Doug that I think part of the discussion to go to protocol is revisiting termination for traumatic arrests, especially for blunt trauma, for adult entities.
Thank you. Ben?
I agree with Mike. So the draft, just sort of high level, basically matches this with the exception of the addition of cardiac arrest, a respiratory rate, a vehicle telemetry, suspicion of child abuse and burns. So I think what Joe's looking for is if there's anything in addition, anything that people feel like we need to either add to ours or that even though it's here, you want to eliminate, if people are okay with these vital signs, that's basically it basically is this with those exceptions. So are people generally okay with that, or are there things people feel strongly about that they don't want us to make changes? Like the ones in yellow are changes I'm okay with, but if anyone feels strongly like, no, we don't want that, it would be good to know sooner rather than later, or we can talk about it later.
So the other thing to consider while you're doing this is like the specific, like to be very specific about what change, what's different from the ACS protocol. So when we put out our protocol, people will understand why we do that.
Understand that the right lower box, okay, which is now labeled EMS judgment, kind of replaces a single line at the end of the previous version, which said, upgrade if EMS providers feel it ought to be upgraded, right? So the attempt there was to provide some guidance as to the kinds of things that might lead an EMS provider to up triage. So, one can quibble with the details for sure, but I think the concept was not a bad one.
Which we do have here, after all those mandatory, these are all things where, and I know Doug suggested adding emergencies, mad, but these are all things that could be serious, consider going to a trauma center. And these are all, some of these are from our previous, some of these are from the new one.
Well, I do suspect that STAC is just gonna, as they did last time, adopt the state protocol hook, line, and sinker and say that that's what it ought to be.
This has been adopted by the state already.
Huh?
This has already been adopted by the state.
No, I don't
The
think
new,
so.
the new guidelines.
It has?
Well, CMAC. I mean, they haven't voted on it yet because there was
I don't
no
think
quorum
STAC,
in
I don't
July.
think STAC, yeah, because STAC, I don't think so, because this came out in April, is my understanding of. STAC, I don't think met, I don't remember when it met. Other hasn't been reviewed.
Any specific comments that the protocol committee needs to take back to review this?
And I think our plan is to finalize the draft protocol, it go to the arts hack for comments, to get the further revision protocol if necessary, and then to be formally presented at the Remac for voting. Right, Pam, I think that's.
Now, again, we might run into, if CMAC does approve this before we get to it, we might run into some problems with that. But we'll have to deal with it.
I mean, I think with this, because of those top two boxes, the only thing is the respiratory rate.
Right.
If CMAC approved this, we probably could present our version and it's substantially in compliance.
Okay.
We probably could get it passed by them, explain.
We'll see. All right, so regional council did not meet, and there was no quorum at CMAC, so we'll skip that. There is the medication list that came out of the medication tag. This was sent out via email to everybody. We began the discussion of medical standards. I think there's a little bit more discussion that needs to happen. There was some questions as to, this draft document of required medications versus having a blanket statement that says you need to complete your standing orders for as the required list of medications, which is the old language. This draft was because that was the ask of the medication tag. The feeling of medical standards was that it might not be needed and it might be better to go with the original language. Again, we'll take this back, look at it and bring it back. Does anybody have any questions on that? Ben and Brad did the bulk of the work on the medication list, which was emailed out to everybody. This is a great document, especially if you look at it in color. It has all the different medications that we use in our system, broken down by protocol, broken down by specific types of protocols. And it's a great document to look at, to kind of use it. It was the basis for this required list.
Yeah, I mean, I think Brad's document's probably still useful now with the hydroxycobalamin and the nerve agent stuff being available. That other one's not really that useful. It's, you know, with the exception of making people realize like, oh, Zofran is mandatory. But I think the main purpose of that other list was to make clear that hydroxycobalamin was not expected to be carried by volunteers.
Right.
And now that that's changed, we don't really need that list. So, I mean, we can kill that one, but I like Brad's to continue.
Okay, and there also was a formula put together by the state, which was approved in 2016, which actually incorporates almost all the medications in this list, other than the specific antibiotics and such that are in the rescue medic protocol. So I will send that out as well as a document for everybody to review, and we will hopefully incorporate that through medical standards into the next Remac meeting to have that as part of our protocol document, not necessarily a protocol per se. That is the only unfinished business that I had. Under new business, the only item I have, and if anybody else has anything, we'll entertain it. But I was asked by one of the transporting agencies to revisit the concept of PCA pumps. Right now, PCA pumps, because they are an IV line, an ALS unit is required to transport that patient. But the feeling is that this is patient-controlled analgesia, which the patient is sometimes going home from the hospital with, and not the crew is just transporting the patient because they can't physically go by another method. Should this be an ALS skill, or could it be transported by a BLS unit? Is a discussion that I think has come up. I think there is language at the state level about it, but if this region feels strongly that we can maybe push that a little bit in the way of BLS for patient-controlled analgesia, but because the language of our protocols are that an IV line has to be transported by an ALS unit, some agencies are forced to have ALS units not available for other calls because they're transporting patients going home on a PCA pump. So again, this came from one of the transporting agencies. Any comments on that? Anybody have any thoughts on it? Please.
Just from a practical perspective, I believe that if the patient is able to manage it, that an EMT would be able to observe that and not, the EMT is not taking any direct action on the PCA pump, since it's usually locked out anyway, and that there shouldn't be any concern.
Ben and then Jeff.
Yeah, and I don't know how the regulation works. I mean, I think there's a broader question of, for, you know, someone who's being transported from home or nursing home to an appointment or whatever, why a PCA, because it's an IV, should be treated any different than a baclofen pump or an insulin pump, or, you know, I assume that they don't say we can't transport someone on an insulin pump because it's a patient. So if there needs to be regulation or something written that if it's the patient's usual patient control device, like that's an exception. I don't know if that has to happen at the state level, but that's the way I would look at that. If it's the device the patient uses every day, moving them to an appointment or back or whatever should not be prohibited.
Any Jess?
I agree. I mean, just the way we BLS can transport patients with an IV KPO, it's essentially.
They can't with the IV fluid is attached.
I'm saying
But
nothing
if
attached.
the line is attached, they can transport.
So
there's a line attached and it has to be an ALS unit, which is, I guess, part of the problem.
Okay. And also the BLS crew has Narcan if they need to. But the question I have is, how often is this and what are they looking for? They're looking for a memo or something or?
Again, it happens
agreement?
often enough, in the interfacility world that people are going home on patient control, especially now with, people, being taken care of more at home. But it is something that's come up and it's generally gone the ALS, it's a billing question, because you can't bill for the service, yet at the same time, you have to have an ALS unit, running on that
Sounds
default.
like a good regional update.
I think there might be distinctions between discharges and. facilities. And then patients, if you're being transferred and you have, and you need a PCA, it just seems to me that there's something going on, that there's a high level of care, and that probably be to some extent dropping the level of care. Whereas when you're discharging someone, you're essentially saying, this patient is ready to be home. And so it's an appropriate level of care would be BLS, but on a transfer, the appropriate level of care probably is ALS, not a transfer.
So, let's just let protocol discuss this and make the recommendation.
Again, I'm not sure that that the protocol have the answers to that. It's either gonna be in a
I think
facility
it's a state issue first.
or,
Then spoke for.
should we,
Maybe, but
document that
why
goes
not?
to the state?
Why not? Why not? But why not have protocol discuss it? I mean, you don't want to do committee work in the mail,
Good, all right, Pam. If you could get us some answers on this, we'd appreciate it. Ben,
No, I was just gonna say, that someone should, the first step is to look into and figure out, is it a state regulation, because that's what happens, us, that we should CMAC or DOH to change it. If it's maybe our rules that.
But we want to tell them how to change it too, right? We think they should change it.
okay, it is now 10 to 7. Is there any other discussion? No. Thank you. Have a great night, everybody. Thank you very much.
Yeah.